les damos la más cordial bienvenida a la Conferencia Magistral Epidemiología de la Demencia en Latinoamérica, Hallazgos del Grupo Demencia 1066 en la República Dominicana, a cargo del Dr. Martín Prince. A seguidas, ofrecemos salutaciones a los integrantes de la mesa de honor. Dr. José Rafael Espaillat, vicerrector de Gestión y Extensión de la UNPHU. Dr. Martín Prince, conferencista. Doctora Daisy Acosta, investigadora. Licenciada Josefina Pepín, vicerrectora de Proyectos, Investigación y Vinculación de la UNPHU. Y doctor William Duque, decano de la Facultad de Ciencias de la Salud de la UNPHU. Sean todos los presentes, decanos, directores y todos invitados estudiantes, bienvenidos a esta conferencia. A continuación escucharemos las palabras de bienvenida a cargo del doctor José Rafael Espaillat.
Muchas gracias, buenas noches. Es para mí un honor dirigirme a ustedes y a la mesa de honor con el motivo de la charla titulada Epidemiología de la Demencia en Latinoamérica. Mi área de experticio profesional es muy lejos de la medicina. Y cuando yo vi ese título de Epidemiología, dije, wow, pero yo tengo mucho que aprender aquí. La epidemiología de la mente es algo que suena bien fascinante, ¿verdad? Bastante a ciencia de avanzada, ciencia de futuro. Y precisamente a nosotros nos enorgullece mucho poder ser seleccionados, no solamente para hacer esta presentación, sino ser los depositarios del proyecto del Banco de Cerebros que la doctora Daisy Acosta pues desarrolla en coordinación con otros médicos y doctores de otras instituciones aquí en nuestro país. Esta conferencia viene hoy como algo simbólico porque precisamente la semana pasada nuestra Escuela de Medicina fue acreditada por el Ministerio de Educación Superior, Ciencia y Tecnología, junto a la Escuela de Medicina de dos universidades hermanas, la Universidad Pontificia Madre y Maestra y la Universidad Autónoma de Santo Domingo. Para nosotros es un orgullo, de manera tal que ustedes estudiantes, los que no lo sabían ya lo saben, y acérquense a su decanato para cualquier información relativa a qué significa eso para ustedes y cómo ustedes en un futuro egresado de la universidad pues recibirán los beneficios de esa acreditación. De la acreditación nacional, nosotros estamos buscando la acreditación internacional, lo cual estamos trabajando fuertemente, y el decanato, bajo el mando del doctor William Duque, pues está trabajando en él. También me gustaría aprovechar estos minutos para destacar que la semana pasada en este mismo salón nos tocó inaugurar un taller, unas sesiones de capacitación que se van a hacer a 260 encargados de centros de emergencia y áreas afines de hospitales de nuestro país, con el objetivo de brindarles nuevas herramientas para el diagnóstico certero de cualquier sintomatología que le llegue a la sala de emergencia. Esto lo estamos haciendo a través de un laboratorio que ustedes estudiantes ya conocen, el laboratorio Cosmos, de simulación avanzada, la cual la universidad no escatimó esfuerzo en tenerlo a la disposición, para tenerlo a la disposición tanto de los estudiantes como de toda la sociedad dominicana. Estamos hablando que personal del 911 estarán entrenando en este laboratorio, y con este entrenamiento que se inició este sábado pasado, este viernes pasado, pues ya nosotros iniciamos ese proceso de mejorar, incidir, tratar de colaborar con lo que es el diagnóstico de las enfermedades, uno de los graves problemas que existen en nuestro sistema de salud. Así es que sin más, muchas gracias por todo y Nos vemos. Ahora.
A seguidas escucharemos la semblanza del doctor Martín Prince a cargo de la doctora Daisy Acosta.
Pues muy buenas noches a todos. Para mí es un verdadero placer presentar al doctor Martín Prince. El doctor Martín Prince es profesor de Epidemiología Psiquiátrica y codirector del Centro para Salud Global de Salud Mental del King's College de Londres. Se entrenó en psiquiatría en el Hospital Maudsley y en epidemiología en la Escuela de Medicina e Higiene Tropical de Londres. Su trabajo está orientado a los trastornos de salud mental y neurológico para crear políticas sociales en países de bajos y medianos ingresos, con un foco en el envejecimiento y en la demencia. Él ha coordinado desde el 1998 el Grupo de Investigación de Demencias 1066, que es una colaboración de investigadores, principalmente de países de bajos y medianos ingresos, que trabajan juntos para promover una mejor investigación en estas regiones. El grupo ha publicado unos 140 artículos cubriendo la prevalencia de la demencia, incidencia de la demencia, la etiología y el impacto de la misma, y ha contribuido al conocimiento de salud pública en estos aspectos de envejecimiento y enfermedades crónicas en países de bajos y medianos ingresos. De manera que su trabajo ha tenido un tremendo impacto para que los sistemas políticos y de salud puedan realmente establecer medidas contra estas enfermedades. Él es coautor del reporte de demencia que hizo el Reino Unido para desarrollar su estrategia nacional de demencia en el Reino Unido. Él ha desarrollado muchísimos reportes para la Organización Mundial de Alzheimer, como por ejemplo el reporte de 2009 sobre prevalencia y números de personas con demencias en el mundo. En el 2010 hizo un trabajo sobre el costo social de las demencias y en el 2014 otro enorme reporte que ayudó muchísimo respecto a los factores de riesgos modificables para las demencias. En el 2015 hizo una puesta al día de esos reportes en prevalencia, incidencia y costo, y fue el líder del reporte que realizó la Organización Mundial de la Salud junto con la Asociación Mundial de Alzheimer para el desarrollo de este reporte que causó mucha sensación, llamado Demencia, una prioridad de salud pública. Él ha sido uno de los 3 editores de la serie publicada en la revista Lancet, una de las más prestigiosas en el mundo, sobre la serie global de salud mental. Él se ha comprometido a seguir investigando para crear abogacía y soportar ese llamado de atención para mejorar la cubierta y las evidencias para el tratamiento comunitario y de salud de las demencias. Él coordina y desarrolla, fue coordinador y desarrolló, y esto para mí es muy importante porque es una de las cosas que más estamos usando a nivel de atención primaria, lo que llamamos las brechas en salud mental, o la famosa guía de atención para las demencias, llamado el MHG. Señores, pues con ustedes el doctor Martín Prince, que realmente yo no sé si sabemos el orgullo y el honor que es el tenerlo con nosotros. Buenas noches, Martín.
Buenas tardes, buenas noches. Unfortunately, I'm going to be speaking in English, so those that have the headphones can listen to the translation. I'm sorry for that. entiende mucho con español, pero por hablar es muy difícil. I'd like, first of all, to thank very much the Rector and the Dean and the Vice-Chancellor for inviting me here to give this talk. That's a real pleasure and an honour as well. I'd like to thank Dr. Daisy Acosta for her kind introduction, but also for the 20 years now of research collaboration and friendship. It's really been very much appreciated. Everything that you hear about our work in Dominican Republic is about Daisy and her colleagues. And the rest of the things that you will hear will be about all of the other colleagues in our 1066 Dementia Research Group from 7 countries in Latin America and the Caribbean, from China, from India, many of whom, nearly all of whom, are here with us in the audience tonight. So afterwards, perhaps you will get a chance to meet with some of them and ask them some questions as well. We've all been working together for the last 20 years, since 1998, going on a journey to explore this problem of dementia and Alzheimer's disease. A condition that affects, unfortunately, many older people to varying degrees, and has, as you'll see later in this talk, a huge impact on their lives, and in particular the quality of life, and that of their family members who provide care for them. And at the very beginning of our work, it was very clear that while in high-income countries like my own in Europe, the United Kingdom, we struggle really to provide good healthcare and good support for people with dementia. In low and middle income countries where there are few resources, but there are just as many people with dementia, the situation is that much more complicated. And that was the situation that we wanted to try and address through our work. So why the 1066 Dementia Research Group? Well, when we started back in 1998, we estimated that only about 10% of all of the research worldwide into the problem of dementia was carried out in low and middle income countries, but that actually nearly 2/3 of all people with dementia, 66%, were living in low and middle income countries. So our aim was to try and make a better balance between where the research was being carried out and where the problem existed in our global population. And our aim, given that there was so little research, was to do research, not just for the sake of research, but to raise awareness about this problem amongst everyone who needed to know, amongst the population in general, in communities, health professionals, but also particularly policymakers and decision makers, so that our research would shape policy and also inform healthcare and social care practice as well. And there's the website address. We work very closely with Alzheimer's Disease International, the international organisation of all of the national charities, non-governmental organisations that support people with dementia and their families. And if you want more information about our projects, our research protocols, the questionnaires that we use, the findings of our research, the publications that we have released over the last 20 years, you can find out a lot of information about it there. Now, I'm going to be talking about the 1066 Dementia Research Group and its work, but also something called the Global Observatory for Aging and Dementia Care, which we established at King's College London, my university, back in 2009. And we've been working with Alzheimer's Disease International every year to produce a World Alzheimer report, focusing on the latest facts and figures about the numbers of people with the condition worldwide, where they live, about the rate at which new cases develop worldwide, the economic cost of dementia. My goodness, that report had a big impact. As soon as you start talking about the economic cost, this really makes the world's media and policymakers listen and think really about the importance of this health condition. But we've also looked at every aspect of care for people with dementia. in 2011. Why is it important that people with dementia receive a diagnosis early in the course of the illness? Because often people receive a diagnosis late on or not at all, by which time their family is under a lot of pressure and things can sometimes be extremely difficult at home. Early diagnosis can help to reassure the person living with dementia and the family, and can mean that they access the help that they need early on and at the time when they need it. We looked at long-term care for people living with dementia, because unfortunately, dementia being a degenerative disorder of the brain gets worse over time, and problems with memory can turn into problems with language, problems with thinking, concentration, all aspects of cognitive function, and can even turn into quite a physical disease, problems with behaviour that can affect the person with dementia and the family as well. So needs for care in dementia start early and get more and more over time, until often families are providing 24-hour supervision and support for the person with dementia 7 days a week. Imagine what that means. We looked at possible ways of preventing the onset of dementia in 2014, and in 2016 we looked at the whole health system issues for dementia and ways in which health systems could be structured better to provide good quality care around the world. I want to just thank everyone at the beginning, just to orientate people to all the important players who've supported our work through the years. Alzheimer's Disease International have been very important, as I've mentioned. So I'm not sure actually who in our group is here with us tonight. I'm just scanning through the audience, but Juan Gibre Rodriguez from Cuba is here, Daisy Acosta from the Dominican Republic, Huang Yuqin from China, Beijing, I'm not sure he's here this evening, Quiles Salas from Venezuela, Ana Luisa Sosa from Mexico, Maria Guerra is here from Peru, Richard Owakwe from Nigeria, and Malan Hayes from South Africa are not here. We've received funding from various funding bodies over the years. The work in Dominican Republic was supported first by the World Health Organization, then by the Wellcome Trust, and the current third wave of the project is supported by the European Research Council. And I have a lot of friends and colleagues in London who've been supporting us with this work as well. Now let's start by thinking about one of the really important background issues to this talk, which is population aging, demographic aging. This is a worldwide phenomenon. All around the world, older people are living for longer, and at the same time, fertility rates are going down. So the absolute numbers of older people in all countries is increasing, and older people as a proportion of the total population is also going up at the same time. And this one slide tells the story of the effects of population aging. If back in 1950 you asked the question, where do older people live? The answer would be, well, about half live in rich, developed countries, and about half live in poor, developing countries. But look how that proportion changes through to 2050. By 2050, 80%, 4 out of every 5 older people on the planet will be living in what are currently low and middle income countries, and only 1/5 in high income countries. So when people think of old countries like the European countries as being where aging is happening, where aging is all about, that's actually not the case. We need now urgently to be looking at the situation around aging and older people's lives and the support that is available to them in low and middle income countries. Here's the situation in Latin America and the Caribbean. The number of people aged 60 and over. In 2010, it was just about 57 million were aged 60 and over. 115 million by 2030. 184 million by 2050. The numbers are nearly doubling every 20 years of older people in these regions, while the numbers of children are actually going down, and the numbers of middle-aged people, working-age people, are staying about the same. There's fewer young people and people in active employment to support economically and in other ways older people. And global population aging has led to a number of different discussions and discourses going on. So one narrative says, this is great. It's a triumph for mankind, isn't it? That in the last century, in many countries in this planet, if you survived childhood, you had a very good chance of living into your 70s or even your 80s. And the idea that older people are, in some way a drag or a drain on society, that they are all in some way dependent and need support, is wrong. Actually, older people are a resource for countries. Why? Well, they share wisdom and knowledge that they've accumulated across the life course. Actually, older people can be quite wealthy. They build up assets over their life course, and they share those with their children and with their grandchildren in the community to boost education and to improve the livelihoods, the situation, the economic situation of their family. But at the same time, it is undoubtedly the case that older people have more chronic diseases than younger people. And chronic diseases lead to disability, and disability leads to needs for care. And that's social care, care from the family, but medical care as well, which can be very expensive. So the more older people you have, the more chronic disease you have, the more needs for care you have, and the more the societal costs increase. And that led Standard & Poor, who set the credit ratings for countries around the world, said that actually global aging is the single biggest threat to the stability of the global economic system and sovereign debt. That high-income countries like my own have only about 15 to 20 years to think through long-term care and how they will pay for it. Middle-income countries like yours have perhaps a little longer, 30 years or 40 years, until that crunch comes. We shouldn't panic, because this needs a national discussion, and governments need to be open about this and say, we have a problem unless we address it, and we need to make decisions about what kind of support and care we think it's reasonable as a nation to provide for our older people, and how we're going to fund that, how we're going to pay for it. But changes will be needed, and efficiencies in care, as we'll see in a minute, will be needed as well. So, having said that, I'm going to go back to the beginning in 1998 and just tell a little story. That's India. There's an elephant. That was our very first meeting of our 1066 Dementia Research Group in 1998, where at the Alzheimer's Disease International Conference, that was the first time a major dementia conference had happened in a low or middle income country. We decided just to open the doors and say, is anyone here interested in doing work in low and middle income countries? Come to a meeting. And we had about 30 people come to the meeting, and we talked through what were the priorities, the work that was really needed. And we decided we needed descriptive research to know how common dementia was and what were the numbers affected in different world regions. We needed to study the risk factors, because they might be the same or they might be different in low and middle income countries. Absolutely essential to look at care arrangements. We know that people with dementia need a lot of care, but in different cultures, different societies, how is that care arranged and paid for? In my country, a lot of the care is done by paid carers, or even in residential homes. In traditional societies, nearly all of the care is provided by families, but frankly, there isn't really an alternative to that. So what arrangements do families make to be able to cope with all of this? And we also thought it very important, right at the beginning, to think about interventions that improve the lives and health and well-being of people with dementia and their carers. I move forward a little bit. Daisy will remember this photo. Daisy Acosta and and a Brazilian colleague came to London, and we did some training on research methods for epidemiological studies in dementia and chronic disease epidemiology. And Daisy, through Raul Mena on the right, who very sadly passed away a year or two ago, a neuropathologist from Mexico, a very passionate man about dementia, really wanting things to move on in his region. He arranged some support from PAHO, and Daisy was able to train investigators from a number of Latin American countries. And this is really one of the reasons why Latin America and the Caribbean, Hispanic Caribbean, are so strongly represented in the work of the group, down to Raul Mena, the godfather, and Daisy Acosta, the godmother of the 1066 group in the region. And the protocol for the 1066 studies, at least for the population-based studies that we carry out, is really extensive. We tend to spend a whole morning in the older person's house. We interview the older person, we assess their physical health, we examine them, we interview a family member at the same time, we carry out a blood test, taking a fasting blood sample to diagnose conditions like diabetes and anemia. We measure the blood pressure level as well as other factors. And the centre of all of this, though, is the effort made to diagnose dementia. And many of you, the students and young doctors here, will know that when you diagnose dementia, you need to do three things, don't you? You need to carry out some cognitive tests to test the memory and other cognitive function, to look for evidence of cognitive impairment. You need to carry out a physical examination and a mental health examination to see if there might be another reason for confusion other than dementia. But the third most important thing is you ask the family, because the older person often doesn't have insight into their problems. But you ask the family and they will say, yes, the last 6 months, the last 1 year, I've seen some decline, they're forgetful, they're getting confused all the time, their behaviour is changed, they're not interested in reading or watching the television. So our approach in our studies just applies a very structured system to obtaining that diagnosis. The pilot study was about developing that diagnosis and validating it in 26 countries in Latin America, China, India, Russia. The population-based surveys have been conducted in 12 countries now, and that was the first, or so-called baseline stage, completely descriptive, looking at the prevalence of dementia and other health conditions and their impact on disability, needs for care and economic cost. The incidence phase was about looking at people who didn't have dementia at the beginning of the study, following them up for 4 or 5 years, and seeing who developed dementia, who didn't develop dementia, and which risk factors at baseline might explain who developed dementia and who did not. We carried out a nested study called the in-depth study to look at the impact of having an older person living with you in the household on the economic and social functioning and dynamics of the household. And like most of our research, this was a cross-cultural comparative study. We did the study in Peru, in Mexico, but also in China and in Nigeria, very different cultures. And we're now on the third wave of our 1066 study, Life to Years 1066. We visited Villa Francesca neighbourhood in Santo Domingo this afternoon. It's 12 years since we started the first study, number 1, and we're now going back these 12 years later to see what has changed. Is the prevalence of dementia going up? Is it about the same? Is it going down? Are conditions like hypertension, diabetes being better detected, better treated than they were before? There's many changes happened in the Dominican Republic over that time. Some of them very good changes for older people. For example, an increase in pension availability and better health insurance than existed before. So many of the difficulties and uncertainties that older people faced in their lives back in 2003 may now be much improved. But what is the effect on that on their health status? These are the countries who had had dementia studies when we started our work back in about 2003. And you can see that the regions of the world marked in red, there were many studies, population-based, of the epidemiology of dementia. We had a good idea of the prevalence and the distribution. The regions marked in pink, China and India, there were a few studies, not of very good quality, and we really weren't very confident of the prevalence of dementia. The rest of the world, marked in white, there'd either been no studies of the prevalence of dementia or just very sporadic studies with the tiny little red dots. So these were the countries where we set out to carry out prevalence studies. And you see how our work was really trying to fill in the gaps in the evidence base. How do you do a prevalence survey? Well, what you need is a sample, and the sample needs to be representative of the population that you're studying. So here is Daisy and Guillemina in 2003. Daisy looks just the same, like me. And these are our catchment areas. And you see we draw a line around the map, and we map every single household in the area. In Villa Francesca, that's very difficult. It's the same when we went today. There's a big house on the street, you go down an alleyway, and there's 10 or 15 slum shacks behind, often with older people living there under extremely difficult and challenging circumstances. But we try and knock on every door in the neighbourhood and identify every older person aged 65 or over and invite them to take part in our study. So in a way, we don't take a sample, we actually identify every older person, and every older person has the right to participate in our project. I'm going to show you a few pictures, take you on a journey. This picture is Dominican Republic. And the gentleman on the right, Don Pedro, sadly deceased now, actually lent us one of the rooms in his house to act as the office for the study while we, with the interviewers, were working in the area back in 2003. Here we are in rural China. So many diverse populations have taken part in this global study. This gentleman, 93 years old, is still running his own shop, single-handed, in India, economically productive, looking after himself, contributing to the family. This is our rural site in Peru, Canuelas province, badly affected by an earthquake back in 2008. And this is again the same site in Peru. This is a famous polyclinic in Cuba. Havana and Matanzas are two sites there. This lady here, I've included her because back then she was the oldest participant in our study, Esperanza, lovely name, 101 years old. She was overtaken, I don't have the photo of the lady, but in this shack in Morelos province, outside Mexico City, again affected by the earthquake just the last few weeks, lived a lady 106 years old, quite healthy, no dementia, cognitively intact, and her 89-year-old daughter, as well as other family members. Now, across such a wide range of countries, you find very, very diverse circumstances. Here we see the percentage of the population who are 80 and over. That's the percentage of our sample in black. The red are those that are illiterate, cannot read or write, and the pink are those that have no education. And you can see that the Dominican Republic, which is the second line there, is quite high on all three indicators, in fact, particularly compared to other Latin American countries. So low levels of education in the Dominican Republic population. But you look at India, rural India, and you see that 80% of the older population are, nearly 80% are functionally illiterate and have no education at all. This is a really important question. Income support from family and government or occupational pension. The pension is the red bar, the income support from family is the pink bar. Countries like the Dominican Republic that have low pension coverage tend to be highly reliant on support from families. But you can see that Cuba, Venezuela, Peru, and Mexico, urban, all had at that time higher levels of pension support than the Dominican Republic, and were less reliant on family support. So not surprising perhaps that back then in 2003, food insecurity, which was older people saying they went hungry in the last month because they did not have enough money to buy food to eat, is unfortunately, or was unfortunately, relatively common amongst the older people in Dominican Republic compared to Cuba, Venezuela, or Peru, though you can see how common food insecurity is in the urban and rural populations in India. It's a basic indicator of extreme poverty. And the other thing that's really important is social protection from the family, because the family is the ultimate guarantee for an older person should they find themselves in a difficult health situation, a difficult housing situation, a difficult economic situation. This is the proportion of older people that didn't have any children available to provide them with support. And there's two reasons. One is infertility, you never had any children. And the other, that's the white part of the bar, the other is migration, where children have moved away. And of course you can see in the Dominican Republic, migration is a big issue, that many of the older people do not have children to provide them with support here in Hispaniola, because their children are in the USA. Yes, of course they send money, but if they need practical support from their children, the children are not there to provide it. And I suspect this is a trend that has continued since 2003. I show those slides to perhaps offer a potential explanation for why we see these, comparatively speaking, very high rates of depression. Sorry, it's the second bar, it isn't marked, between Cuba and Venezuela, sky high. The prevalence of depression, clinical depression, in the Dominican Republic population. So we have a population here who in 2003 had low pension coverage, low health insurance. Many of the older people were living with their children not available to provide them with support, migrated to the US, and the high rates of depression. There may or may not be a causal link. The thing to note about the Dominican Republic, and this is a paper that Daisy published in BMC Public Health back in 2010, looking at all of the different chronic diseases. So you can see diabetes that hasn't been diagnosed, diabetes, hypertension, metabolic syndrome, stroke, dementia, and anemia. And if you look at the right-hand column, that's comparing the prevalence in the Dominican Republic with the prevalence in the USA. And if it's 100, then the prevalence is the same in Dominican Republic compared to the USA. If it's more than 100, there's a higher prevalence in Dominican Republic. If it's less than 100, there's a lower prevalence in Dominican Republic. So you can see that already the prevalence of lifestyle chronic cardiovascular diseases like diabetes and hypertension is either nearly as high or actually higher in the case of hypertension than it is in the US. And the prevalence of stroke is the same, and the prevalence of dementia is very similar. But anemia, which is basically a disease of poverty in older people, poor diet, poor nutrition, is 3 times more common in the Dominican Republic compared with the USA. Hypertension in older people in all of the different countries covered by 1066. And you can see that in urban sites, about 3/4 of all older people have hypertension. And in the rural sites, it's nearly a half of the older people have hypertension. And any cardiovascular disease risk factor on the right, well, practically all of the older people have at least one cardiovascular disease risk factor. But how well are these cardiovascular diseases managed in the different countries? What you can see here is that 76% of the Dominican Republic population had high blood pressure, and most of those have actually been detected by the health service. 82% of the older people with high blood pressure knew that they had high blood pressure. But only 48%, half of the cases that were detected, had actually been controlled properly with antihypertensive drugs. It's not difficult or expensive to control hypertension. So the fact that only just over 1/3 of all high blood pressure is being detected and controlled is a worry. The health system should be doing better than that. This was 2003. We're going back now to see if the situation has actually improved. What about the prevalence of dementia? concentrate on the red bars here, which is our own 1066 dementia diagnosis. And you can see that across most of the Latin American sites, somewhere between about 7 to 10 or 11% of the older population is living with dementia. Dominican Republic was actually one of the highest prevalences, 11% overall, although actually the highest prevalence we've ever recorded was in a black African Zulu population in Bloemfontein in South Africa. Small study, very possibly related to the high prevalence of HIV, even in the older population in that area, though we were never able, strictly speaking, to confirm that. So with these data, we started to have a much clearer idea of exactly how common dementia was, certainly in the Latin American region. And these prevalences look very similar to, or even higher than those that one sees in high-income countries. And we followed everyone up, as I mentioned, 4 to 5 years later, and now we're looking at the rate at which new cases of dementia develop every year. And these are expressed per 1,000 people per year. So divide it by 10 and that gives you the percentage of new cases. So it's somewhere between about 1.5 to 3% of older people develop dementia each year is what these rates are telling you. And that rate is actually, if anything, slightly higher than you see in high-income countries. Some people had expressed the view that dementia was actually much less common in low-income countries than in high-income countries. But when, for the purpose of the World Alzheimer reports, we brought all of these data from the 1066 studies, and in fact a total of 146 prevalence studies that we found through a systematic review that had been done all over the world, and we then meta-analysed those results, this is what we found. Concentrate on the red bars, which is our latest 2015 estimate, and essentially in almost every region of the world, the prevalence of dementia looks about the same, somewhere between about 5 to 7 or 8% of all older people aged 60 and over living with dementia. Possibly a slightly lower prevalence in sub-Saharan Africa, but very few studies have been done there. And you can see that in the China region and then in the sub-Saharan African region, our estimates of prevalence in 2015 were higher than our estimates in 2009. That's not because we actually think the prevalence has gone up, it's just that we have more evidence from more and better studies, and we think we're now estimating it more correctly, and that the previous estimates were in fact underestimates in that region. So what does that all mean regarding the number of people living with dementia worldwide? This is the picture as we see it about now, 2015 in fact. The grey bar on the bottom right, that's the total number of people living with dementia worldwide. 46.8 million, nearly 47 million people with dementia. And you can see from the bars in the different world regions that there are more people living with dementia in the poorer south of the planet than the richer north of the planet. And then keep an eye on those bars in the south and the north as we scroll forward from 2015 to 2020 and on through to 2050. And you can see the blue bar in Asia and the red bar in Latin America and the blue bar in Africa shooting up there. So actually, over those 35 years, we see nearly a doubling of the numbers in high-income countries in the north, in Europe and North America. We see a trebling of numbers in Asia. We see a quadrupling of the numbers in Africa and in Latin America. Latin America is a hotspot for dementia and aging and age-related conditions. That's because demographic aging is happening much more rapidly in regions like Africa, Latin America and Asia than it is in the developed north. Here from our 2015 World Alzheimer report, and you can download all of these reports if you're interested from the Alzheimer's Disease International website, free of charge, distribute them freely, please do. This is all about advocacy and letting people know. We have the numbers of people with dementia and the way that we see those increasing over the next 35 years. But what I want to draw your attention to is that we estimate 10 million new cases of dementia every year. That's one new person developing dementia about every 3 seconds somewhere in the world. The overall cost is already $818 billion US dollars. That will increase to $1 trillion US dollars by 2018, and that will then double again to $2 trillion US dollars by 2030. This vastly exceeds the global economic cost of all of the cardiovascular diseases added together. Dementia is extremely under-prioritized in research, in the search for prevention and for cure, and strategies in that direction, and in healthcare as well. And we badly need to do something about that. Here's why. Looking at Latin America again, you can see the rate of the increases in the numbers of people with dementia. Red bar Latin America, black bar Caribbean. North America, Canada and the US, is the pink bit. So you can see the numbers are going up, but not that much in North America. And sometime in the next 5 years, there'll be more people with dementia living in Latin America than in North America. And that will change even more following after that. In the Americas, you can see that even within Latin America, the rate of increase is not the same everywhere. Actually, in the Caribbean, the rate of increase is a little bit more modest. And in the southern cone, Chile and Argentina, it's lower. But in the central zone and the Andean zone, it's very high indeed, the rates of increase. And just look at the contribution of these two big countries, Brazil and Mexico, alone to the overall increases projected through to 2050. Actually, about 8% of the total incidence of dementia is going to be coming from Latin America. And I think this is one of the more important slides for policymakers that we prepared for the 2015 report, because I think still there's a sense that dementia is an issue for high-income countries, not for low and middle-income countries. In terms of where older people live, it's mainly the pink part of the bar, isn't it? And the red part of the bar is the G7 countries, the world's richest countries. The pink part of the bar is the G20, the world's richest 20 economies, but without the G7. So what countries are we talking about here? We're talking about countries like Brazil, Mexico, India, China. It's these middle-income countries that are growing rapidly in their population and growing rapidly in their economies. That's true of where older people live, it's true of where people with dementia live, it's true of where the increases in numbers of people with dementia are going to be coming from as well. So I said Dominican Republic could be a hotspot, Latin America could be a hotspot. It's these G20 countries that are not the world's richest countries where it is all going to be happening over the next 35 years. Why is dementia important? It's important because it affects the brain and the mind. We looked in our 1066 studies at which chronic diseases were making the biggest contribution to disability and needs for care. The answer in both cases was clearly dementia, way out ahead. Second was stroke, which is a disease of the mind or brain. Second was limb paralysis or weakness, which is just stroke that hasn't been diagnosed. Third is stroke. Fourth is depression, another condition of the mind or brain. The brain is such an important organ for maintaining independence and quality of life in older age. We don't see cardiovascular disease here, we don't see cancer here. These conditions make their contribution because older people die earlier. They don't make their contribution through years lived with disability. But for a society, for a government, such as the one here in the Dominican Republic, years lived with disability is a critical social, economic and fiscal issue. So, finally, what do we do about this? Well, the first big issue that needs to be addressed is the diagnosis and treatment gap. Even in my country, only about half of people with dementia have had a diagnosis. If you don't have a diagnosis, by definition, you have not accessed evidence-based treatment and care. The evidence that we have from countries like Brazil, Thailand and India suggests that probably fewer than 10% of people with dementia in those countries have ever received a diagnosis. So the other 90%, no access to treatment or care whatsoever. World Health Organization has a global action plan on dementia, which is excellent, but the implementation of this plan will be critical. We worked with the WHO to develop the Mental Health Gap Action Plan guidelines. These are all about the idea that if you're going to manage dementia, for example in a country like Dominican Republic, there are not enough specialists, psychologists, psychiatrists and neurologists to do that job, given the large number of people with dementia. You must use non-specialists. So we need to have guidelines for the types of interventions that non-specialists in primary care can deliver that make a difference for people with dementia and their carers. And it's not rocket science. Because people don't come for help, you need to go out to them in their own homes, identify people with problems in the community and offer them help. And we've shown you can train community health workers for just 2 or 3 hours about what is dementia. If there was somebody with dementia living next door to you, what might you notice, what questions to ask, and they can actually quite accurately identify people with dementia in the community. You need a brief screening assessment that the doctors or the nurses in primary care can use. And our screening assessment just has 5 cognitive test questions and 6 questions that you ask the family member. And it's quite accurate at identifying people with dementia in the community. You need to make the diagnosis, but in a way that opens the door to the person with dementia and the family to a commitment to continuing care. There's no point saying, I'm sorry you have dementia, there's nothing we can do. That's worse than doing nothing. And what people with dementia and their families need is to be reassessed frequently because the condition changes over time and their needs change over time as well. And only if you see them every 3 to 6 months, you can say, come anytime and see us if you have a problem. But if you don't come, is it all right if we come and see you, perhaps visit you at home, and just see if there are some needs that we might be able to help with. Physical health is really important with dementia. Imagine you have dementia, but you're developing cataracts, so you can't see so well. Life in the world is more confusing than it needs to be. Or perhaps you need a hearing aid, or the wax taken out of your ear. Or you have a pain in your hip, that's making you agitated, so you're aggressive and shouting out and not sleeping. All of these things can be identified and they can be treated. But the key thing is the continuing care across the course of the condition. And we should never forget that older people in general, and people with dementia in particular, almost never have one condition. They have multiple health conditions. And it's the multiple health conditions, the number of conditions that you have, that predicts your needs for care and also the cost of health services, for example, through expensive admissions to hospital. But this multi-morbidity means that you need to think in a different way. As doctors, for example, you're like Spock here, playing not ordinary chess, but 3-dimensional chess. Yeah? Treatments for depression, antidepressants, don't work for people with dementia. We don't necessarily understand why that's the case, but you need to try a different approach. So your clinical evidence changes in the presence of dementia. Actually, everything changes in the presence of dementia. But you should never treat one organ. Please always remember this with older people. Yes, they might have a heart problem, but don't treat the heart, treat the person. What's important for them? What are their priorities? What are their values? What are the issues that are really affecting them? And respond to their needs, not just treating their pulse pressure. That's making care patient-centered. Make care continuous and coordinate the care as best as you possibly can. If people have 5 conditions and they're seeing 5 different specialists, that will lead to a lot of cost and also probably a big mess. that will not be in the patient's best interest, too many medications, too many side effects and drug interactions. It all needs to be brought together. So finally, what we need to do is adopt a public health model for dementia care for older people, but actually for healthcare for older people in general that meets their needs. The first thing is, in low-resource, low- and middle-income countries, we need to centre care on non-specialists in primary care. We call this task shifting. So some of the work that Dr. Daisy Acosta does in her consultation room could actually be done by non-specialists that Daisy could support through training and through visits and facilitation. It would make her life easier because she could concentrate on the really complicated cases and the problems that primary care hadn't been able to sort out. This will increase the coverage of services. More people with dementia will be able to get a diagnosis and get basic care. So this is about integrating all forms of mental health care, dementia care, care for older people into the normal roles and functions of primary care. And I don't know enough about the situation in Dominican Republic, but most countries where I work, dementia care is not seen as being part of the job of primary care. Their focus is on women, on children, perhaps a little bit on hypertension and some of those chronic diseases, but not really older people. And we need to reduce the barriers to access. Imagine a confused person with dementia living in Villa Francesca who wants to see a doctor because they're ill. They've got to get to the doctor's office on a hot day, perhaps using public transport, wait for a long time, pay a lot of money. Imagine all the difficulties of doing that. You need people, and it doesn't need to be a doctor, it can be a nurse or a community health worker coming and assessing them in their own home. And the financing is so important because if you have to pay out of pocket for the costs of medications and treatments, this then means with a chronic disease like dementia, the costs mount up and up and up. Because it's not just one treatment and you're cured, you go, you pay, you need to go back, you pay again, and this puts a big burden on the families. So finally, this we think is the approach that needs to be tried. It's a new guideline from the World Health Organization called Integrated Care for Older People. And we've developed this over the last 2 or 3 years. And what we're saying here is that we don't want a vertical approach where we have a separate guideline for dementia, because then the government and the doctors will say, okay, but what do I do about stroke? What do I do about Parkinson's disease or chronic obstructive pulmonary disease? Do you have a guideline for that? And we don't want 10 different sets of guidelines on the desk. We want to keep it simple. And the older people probably have a number of these conditions at the same time. So keep it simple and let's go for the impairments on the right that are common to all of these conditions. The community health workers may not be able to make these diagnoses, but they can identify confusion, they can identify low mood, low mobility, incontinence problems, undernutrition or hydration, deafness, blindness, and they can assess the knowledge and needs for support of the carer. So we've carried out research in India so far where we've actually shown that it's possible to train community health workers to identify frail older people who need care in the community, many of whom have dementia, not all, but many of them do. They all have a high prevalence of all of these impairments on the right-hand side. We've shown that the community health workers, using a structured, simple assessment that takes about half an hour to administer, can work out which of these problems on the right is a problem for the older person. And then the key issue is this guideline, the Integrated Care for Older People, that actually says, okay, here is the treatment that you need to be given. So these are the care workers in India who are trained. This is the very simple battery of tests that can be easily administered by these non-specialist community health workers to identify the impairments. And then, of course, we need to think through what the target population is. But I don't think I'm actually going to look through that in detail at this stage, because I think I've shared with you most of the important essence of this idea. It's a public health approach. You know the Sustainable Development Goals, which the UN has supported. one of the main health goals is universal health coverage. Health for all, leaving nobody behind. So this is not only everyone has a right to health and a right to health services, but this actually means that everybody means people living in the poorest countries with the worst resources, in the most marginalised communities. We need to think of them, think particularly of them, in the way in which we design and deliver our healthcare services. And if we carry on with a specialised model, and if we don't think about the extent to which our primary healthcare services, as well as our hospitals, are meeting the needs of older people, we will be letting older people down. We'll be complicating their lives. They won't achieve the best health outcomes and the best quality of life that's possible. And dementia is such an important issue in all of this. It's really, I think, the cardinal condition of all of the chronic diseases that older people experience, because of its high prevalence and because of its disproportionate impact on disability, needs for care and strain in the family. 90% of people with dementia don't have a diagnosis or treatment and care, and we need to bring them something very soon. Thank you very much.
En estos momentos vamos a pasar ahora al momento de preguntas y respuestas. Por favor, pueden ir levantando la mano. Quienes tengan alguna duda, comentario. Sí, por allá, por favor, puede levantarse.
Why is it called the 1066 research program?
So that was way back when we started, when 66% or 2/3 of people with dementia lived in low or middle income countries, but only 10% of the research was being done in low or middle income countries. But what's really interesting is that through our efforts and efforts of other colleagues, we really ought to change the name of our group now, because now there's actually more research of this kind being done in lower middle income countries than in high income countries. I'm very pleased about that. Some of the balance is changing, and in intergovernmental organisations like the World Health Organization and the World Action Plan on Dementia, everyone acknowledges and accepts that this is a big issue for low and middle income countries. To their great credit, the government of the Dominican Republic pushed the World Health Organization to develop their action plan this year. They were one of the 16 or 17 countries who were at the forefront. High income countries, middle income countries like Dominican Republic, and low income countries saying we need a plan from WHO.
¿Alguna otra pregunta, por favor? Levantando la mano.
Sí, que se han planteado extender la investigación al interior del país, porque la investigación se ha realizado básicamente aquí en Santo Domingo, no en la zona rural, y sabemos que hay muchas diferencias.
The life of older people, their situation is so much different in rural areas than in urban areas, and so we wanted to capture some of that. And you saw some of the urban and rural differences that we found. So in some of the rural sites where we work, life also can be very, very challenging, with a lot of poverty, and some older people living in very isolated and not very well supported circumstances. I think there's an assumption sometimes shared by governments, that, at least in a traditional society, everyone has their family, the family will support. Generally speaking, that's true, but the family support is at a cost to them, And there's always this small proportion of older people that cannot rely on that support, and that's where the safety net is important.
A person wants to know if you can do a personal consulting in this year.
Well, as a doctor, you mean, or
As a doctor.
I'm afraid not. You know, my Spanish isn't so good, and really, what's most important is the culture. You know, to look at dementia, to assess that, mental health issues, the care needs. You need somebody from that culture. You have many experts in this country. I won't make any specific advertisements, but there are. And, you know, one hopes that soon in primary care as well, there will be support that will be available. But, you know, I would say to any of you, you know, because I suspect nearly all of us in this room, perhaps, will have been touched by dementia in some way. That's the way that it's going now with population aging. Nearly all of us have somebody in our family who has the problem, or a parent of a friend, or somebody that we know. It's going to go on like that for some time now. So when you hear about this, please spread the word. There's help that is available, should be available. It does make a difference. We don't have a cure for dementia, but the things that can be done can actually support the family and make the life of the family and the person with dementia much more comfortable and much better.
Yo quería responder a la persona que preguntó que por qué no en el interior, decirle que el 1066 es un protocolo abierto, es un protocolo que si ustedes consiguen, por ejemplo, auspicio, soporte económico para hacer esta investigación, por ejemplo en Santiago de los Caballeros, el protocolo es abierto y francamente lo pueden usar. O sea, que no es una cosa que lo tenemos aquí agarradito en Santo Domingo y que no queremos que nadie lo use. Es abierto y nuestros datos también son abiertos para que todo el que quiera publicar, usar los datos, solamente hay que pedir permiso al grupo y definitivamente pueden usar los datos. O sea, que todo es abierto.
¿Alguna otra pregunta? Bueno, tenemos varias preguntas. Pueden levantarse.
More than a question, it's a commentary. I just want to say that thank you for sharing this knowledge, and thank you for doing this for our country and for so many countries. I want to thank you and your team for doing this. I really appreciate it. I hope that someday we can you can find, with the help of so many organizations, a cure or maybe a treatment for diseases. Thank you.
Thank you very much. That's very kind. And again, it's been a pleasure and a privilege to be involved. But particularly, I'd like to say a big thank you to the team here in Dominican Republic. We not only have Dr. Daisy Acosta Guillemina, who's been coordinating the study, Maria and Raquel, who are amongst the interviewers there. It's a whole army of researchers actually for a project of this scale in each of the countries, and it's been a great experience. And of course the older people and their families who've given their time to take part. But thank you.
What was the reason for you and your team for starting this project?
So that's a very good question. I trained as a psychiatrist, and my clinical work is as an old age psychiatrist. So I specialise in assessing older people, their mental health and cognitive problems like dementia. And I became an epidemiologist and public health researcher. My first work was actually entirely in the United Kingdom. But I had a very good friend and colleague from India who said to me, well, you know, it's really interesting this work that you do in the UK, but there's virtually no studies done in India. And I'm going back after my PhD, and why don't we try and collaborate and do a project where I am? So that was actually the first start, a project in Goa in India, and that sparked my interest. But you know, I'm really more than that actually when you found the the situation that many older people lived in under these circumstances. And I think the big thing that I perhaps didn't state enough in my talk is where people don't know, where there's no awareness, where there's ignorance about this problem, there's a lot of stigma attached to dementia. People sometimes feel ashamed that they go out with the older person with dementia, or that people come into the house because they wonder what people will think. And this makes lives for people very difficult. Just increasing the knowledge and understanding that dementia is a health condition. It's not bad behaviour, it's not obstinacy, it's not willfulness. In people in general, and this research can help to do that, can make a big difference.
¿Alguna otra pregunta? Por aquí, por favor.
Hi, I would like to know, is there a national organization or institution that support the investigation? Because, for example, we have the National Council of Disabilities and the National Council of Old People, and I'm pretty sure that the National Council of Disabilities don't know about this because I work there.
Yeah. So that's a very good question, and Daisy will undoubtedly say more on this. So there is a National Alzheimer's Association here in the Dominican Republic, and they were host to the conference at the Barcelona Hotel that all of us went to earlier this week, which brought together the Alzheimer's associations from across Latin America and the Caribbean region. The Dominican Republic Association has been running for a number of years now. But I think you're absolutely right that it's important to reach out beyond our own single condition associations and look at other third sector non-governmental organisations that are more broadly based around issues like disability, ageing, because I think a lot of this is, or ought to be, actually about human rights. I think when you reframe a lot of these issues and problems, not as though these are just things that are happening to older people, but actually, if we're serious about equity and autonomy, then actually we need to respect the rights of older people to be able to access a health service that meets their needs, and that absolutely should include people with dementia. So it's a very good point that you raised, but Daisy might like to say more about the Alzheimer's associations are fantastic. They provide so much information, and of course when there are a few health services, they can be an organisation that can advertise, raise awareness, and people can contact them to get what information there is about the condition and what support is available.
Sí, yo tengo una pregunta. Buenas noches. En todas las enfermedades existe un parámetro de ciertos síntomas que uno puede identificar. ¿Cuáles son los síntomas o los parámetros que existen para uno saber cuando un paciente sufre de demencia?
So this is about what are the symptoms of dementia. Yeah. So dementia is progressive. There are different types, but the types are often a bit mixed together. Alzheimer's disease, vascular dementia, which is caused by a number of small strokes affecting the brain. Some much rarer dementias like frontal dementia or frontotemporal dementia or Lewy body dementia. It depends a little bit on what type of dementia you have, the first symptoms. But with Alzheimer's disease, it's usually forgetfulness. And it's usually short-term memories. So the person can remember things that happened years ago, but something that happened yesterday, they completely forgot. It's not just simple things like forgetting somebody's name, because all of us, that happens to, particularly as we grow older. But it's usually a dramatic failure to actually be able to recall a piece of information that undoubtedly if the person had a healthy brain they would have been able to do. And the memory problem tends to get worse, but then unfortunately other problems begin to start with language, with disorientation, stopping being able to find your way around outside of the home and then inside of the home. But the world obviously becomes a very puzzling place for people with dementia because of the damage to the brain. And if you can't remember where you left your money, then you might think that somebody's stolen your money. And so these are often referred to as delusions. You may accuse family members of having misbehaved or done things that they certainly haven't done. Sometimes you may see things that are not really there, or hear things that are not really there, hallucinations. And all of this can lead to disturbed behavior, which is the biggest problem often for caregivers. So this is sometimes sleeping during the day, but not sleeping at night, wandering all the time, wanting to go out of the house in a way that is unsafe with the traffic, and then sometimes getting so agitated that they can even get aggressive or even hit out at family members. But a lot of these problems, if they do arise, certainly don't arise in the early years, and it's more in the late, middle, or the later stages of dementia that these happen. And in the late stage of dementia, physical factors come through. So often people with dementia find it difficult just mechanically to eat and chew and digest. They can lose a lot of weight, they can lose mobility, they can often end up chair-bound or bed-bound, developing contractures. And the nursing needs of a patient in the final stages of dementia can be intense, 24 hours a day. And in my country, this often means being admitted into a nursing home. But I imagine in a country like the Dominican Republic, with very few facilities of that kind, the family is managing somehow at home, but they would need a lot of support with that sort of activity.
Esta pregunta es para la doctora Daisy. Doctora, ¿cómo pueden integrarse estudiantes de medicina o psicología que quieran integrarse al proyecto de investigación para colaborar?
Nosotros pedimos al decanato, cuando comenzó esta fase del proyecto, el proyecto Life to Years, que reclutaran estudiantes. Justo se lo encontraron que era un mal tiempo porque acababa de comenzar la docencia. Entonces algunos estudiantes se unieron a nosotros, nos ayudaban a hacer los neurológicos, y todavía hay estudiantes que van arriba y nos ayudan en muchos aspectos. O sea, las oficinas están en la 4ª planta del edificio de la biblioteca. La oficina se llama así, Life to Years, y los estudiantes los sábados normalmente van a ayudarnos. Ahora ya el trabajo de campo está abierto, está caminando con entrenamiento arduo. Algunos estudiantes se entrenaron, pero por supuesto ya el entrenamiento pasó. No vamos a volver a reentrenar ahora mismo. Pero hay muchas clases y muchas formas de ayudar. Así que bienvenidos, se conectan allá con Guillermina Rodríguez, que coordina el proyecto, y ya le daremos funciones.
Hi, I have 2 questions. How can we try this kind of people we live with them? I mean, they are our family. And the second is if you have any experience with this project, like especially with some patients about the dementia. I mean, an experience with this kind of problems.
Sure. So, very good questions. You know, when you say about experience, it's when we look at these percentages and these graphs, we forget, you know, sometimes. We interviewed nearly 20,000 people aged 65 and over across the different countries. And I think in the baseline phase, there were about 1,900 older people in our studies in the different countries living with dementia. So there would have been around about 200 people or slightly more living with dementia at the baseline of the project in the Dominican Republic. Those are all individual people with their life histories, their needs. We tried, the investigators in particular, Daisy and her colleagues here, to bring what assistance we could during the course of the project, because when you see some of the situations people find themselves in, we may be researchers, but you can't just simply leave people in that kind of difficulty. But we, through this, I think, learned a lot that it would be fair to say we didn't really know or understand before from the kind of clinical practice that our colleagues did about the reality of the lives that some of these families experienced, the challenges that they had, some of the resilience and resources that they were able to bring to bear. So families are often incredibly resilient, but very innovative in the way in which they structure and organise the care. This study we did in Mexico and Peru, Nigeria and China about the impact of caring for an older person, we called A Journey Without Maps, which was a quote actually from one of the carers in, I think, Mexico, who said this was what it was like. You know, we didn't have a route map, nobody told us what to do, we just found our own way. It was a journey without maps. And I think somehow actually trying to provide some maps and some structure for people so that we can, it is not about displacing what the families are doing, you're actually building on what the families are doing, and you can't really do anything without the family. If the family wasn't there, it would be very difficult indeed. But it's about supporting them to do what they do well, providing them with the information, giving them education about the condition, giving them some training about how to manage, in particular, some of the behavioural symptoms. But above all, always being there, so having somebody who is non-judgmental, who can listen to everything that they're experiencing, because often the experience of being a caregiver becomes very isolating. Though it may be a big family, it's often one person, usually a woman. 86% of the carers in our study were women, who is very much alone in their task of providing devoted care for the person with dementia. And the second question was about
how can we try when we deal with this kind
when you live with some, if you live with somebody with dementia, your grandmother. Okay. So there is a lot of information available from the Alzheimer's Association here in the Dominican Republic, and it seems you speak English well. And Alzheimer's Disease International on its website also has some excellent resources available about general caregiving tips. So it's perhaps a little bit complex to go into just here. These are not actually very complicated things though. There's a lot of things that can be done that are very simple, but just don't always occur to people. So, you know, keeping a routine where possible, making a routine as simple as possible as well, finding out what gives pleasure and meaning to the older person and trying to increase those activities and exposure to those things, being very mindful of safety inside and outside of the home, but increasing where possible the chances for the person with dementia to lead as normal as possible a life, the things that always in the past used to give them interest and give them pleasure. So those are just some of the ideas, but there's a lot, there's more to it than that, certainly, much information available.
Dr. Prince, thank you very much. Por cuestiones de tiempo, ya vamos a cortar con las preguntas y respuestas. De todas maneras, en nombre de la Universidad Nacional Pedro Henríquez Ureña, vamos a dar clausura a esta actividad y vamos a tener ahora un brindis para quienes que quieren hacer cualquier consulta o compartir experiencias. Así que pasen buenas noches y muchas gracias a todos.